Now let's begin with the third section of treatment of prostate cancer, and then in this section we will discuss about the brachytherapy, active surveillance, and also prostate-specific antigen after the definitive therapy for the prostate cancer. The brachytherapy is the direct implantation of radioactive sources, seeds into prostate. So direct radioactive source that gives the radiation and they are directly implanted into the prostate. And the sources are the seeds. It is based on the principle that deposition of radiation energy in tissues decreases as the function of square of the distance from source. So this is why we use this brachytherapy, because it is believed that the deposition of radiation energy in tissue decreases depending on the distance from the source. So as the distance between the source and radiation is decreased, the effectiveness of radiation therapy will be improved or will increase. So that's the basis or principle of the use of brachytherapy, in which the radioactive source is implanted into the organ or into the prostate in this case. This brachytherapy delivers intensive radiation to prostate, and the effect of these radiation will also intensify and maximize because of the decreased distance between the site and the radiation. It minimizes exposure of surrounding tissue. Very, very important function of this brachytherapy, because when we use external beam radiation therapy, the surrounding tissues that are in the area of the cancer, usually that is also affected by the radiation therapy. So in this case, brachytherapy, that is also reduced. So it's a very, very better method of giving radiation therapy. Homogeneous dose is distributed. Imaging assessment of cancer, computer optimized dosimetry. So brachytherapy, now make sure we should be very clear about this. In this, the radiation is given into the gland as a result of in the form of seeds which are implanted into the gland, and it gives the radiation, homogeneous distribution of radiation occurs. The damage of surrounding tissue is also limited in this case. It's imaging assessment of cancer, and there is a computer optimized dosimetry is done. Again, this is the prostate gland, and that's the needle releasing seeds that gives the radiation. Implantation is transperineally through the perineum. The implantation of the seeds is done. There is marked reduction in local failure. Well tolerated. The complications that can be associated with brachytherapy is urinary frequency and urgency, obstructive symptoms, risk for retention and persistent voiding symptoms, proctitis in less than 2% of patients. So there are some complications. It has some advantages and some disadvantages also. The advantages we discussed, it's more source-oriented. It does not affect the surrounding tissues, and there is reduction in the failure of the treatment, and it's well tolerated by the patient also. But some complications that can be occur, which is urinary frequency and urgency, obstructive symptoms can occur, there is risk of retention and persistent voiding symptoms like retention occur, and voiding is effective, and inflammation of the rectum, which is proctitis, is also present. Active surveillance. Active surveillance is a policy of monitoring illness at fixed interval with digital rectal exam, prostate-specific antigen measurements, and repeat prostate biopsies as indicated, unless histopathologic or serologic changes correlative of progression warrant treatment with curative intent. So active surveillance is close observation of the patient. Patient should be closely monitored, and how we can monitor the patient, the most common digital rectal exam that gives the idea if about the texture of the prostate, about the enlargement of the prostate, any changes in the prostate. Then most simple and the method that can be done in the routine office visit as a part of routine clinical exam. Then we have prostate specific antigen levels are very important for the process, how serious is the prostate cancer. The levels should be measured, and that's very helpful. And then finally, the most important is the biopsy. Even we learned about this, that even with the abnormal prostate specific antigen, sometimes the biopsy results are normal. In this case, it's very important that we should repeat the biopsies, prostate biopsies, so we can tell whether there are malignant changes or not. And these active surveillance can be done until the histopathology or serological testing correlative of progression warrant treatment with curative intent. And if there is progress of the disease with all these methods, then we should go for these steps that can lead to the cure of the disease. Early stage disease, the active surveillance is done. Contrast between incidence and disease-specific mortality, high prevalence of autopsy cancer. So we have the active surveillance is very, very important in the early stage of the disease. Contrast between incidence and disease-specific mortality and high prevalence of autopsy cancers. Case selection is critical. Concerns with active surveillance is the nomograms predict which patient can safely be managed. Concerns with active surveillance are limited ability to predict pathologic findings by needle biopsy, multifocality of disease, and possibility of missed opportunity to cure. So all these are the drawbacks or concerns with the active surveillance, their limited ability to find out the pathologic changes by performing needle biopsy, multifocality of disease. If it's multifocal, we can sometimes it is missed, and then possibility of missed opportunity to cure. If we cannot find the diagnosis early, we miss the opportunity to cure the disease. prostate-specific antigen after definitive therapy. Rising prostate-specific antigen after surgery or radiation therapy. Disease in primary site curable by local treatment. Radiation therapy after prostatectomy guided by findings at surgery. So it's very important that we should follow up for the level of prostate-specific antigen after the surgery, after the radiation therapy. That gives us the idea about the progress of the disease. Choline 11 positron emission tomography scan. Biopsy of urethrovesical anastomosis before radiation. Prostate-specific antigen persistently elevated after surgery, no radiotherapy. So persistent elevation is not a good indication. So usually no radiotherapy is performed. Rising prostate-specific antigen after the radiation therapy, we use the salvage local therapy. Considered if disease was curable at diagnosis. Other options are salvage radical prostatectomy, cryotherapy, radiation therapy, and irreversible electroporation. So these are all the, if we notice there is rise in prostate-specific antigen level after the definitive therapy. That definitive therapy can be the surgical treatment of the prostate cancer or the radiation therapy. We should look for the prostate-specific antigen level. That is very, very important for the prostate cancer prognostic factor. So rise in prostate-specific antigen after surgery and radiation therapy, what does it suggest? It indicates the micrometastasis. It means the treatment done for the prostate cancer was not fully, it cured the condition, and there is micrometastasis present after the definitive therapy. So this prostate-specific antigen level after definitive therapy is important to find out because it indicates the presence of small metastasis. The immediate therapy for this after finding out the micrometastasis may not always be required, but it's important that we should know the prostate-specific antigen doubling time. If it's 12 months or less, then we need the treatment. So it's important if the level is double in less than 12 months, usually the treatment is performed. Predictive models, it's important to continue to refine the studies that tells us how is the level of prostate-specific antigen after the definitive therapy is important, and at what stage we need to treat the patient with the prostate specific antigen level that continues to raise after the definitive therapy. So it needs to be refined. Further studies are important. Further statistics are important to get to find out what's the value of this level in the finding of the result of the treatment, and how we can manage the patient with the elevated level or which have micrometastasis present. So that was all about this section. Thank you for watching sqadia.com.